Bismillahirrahmanirrahim. So, with all due permission from Dr. Moeen, who is the compiler of this book, let's get straight into the direct excitatory pathway. Now, before going into that, we have to examine and we have to learn this diagram. So, in this diagram, they are showing you that the green pathways are stimulatory pathways, the red pathways are inhibitory pathways. So you may say that the green pathways are glutaminergic pathways, right? Because we know the glutamate is an excitatory neurotransmitter, and the red pathways are GABAergic pathways because GABA is an inhibitory neurotransmitter. So keep that one thing in your mind first. Now let's move forward. The second thing that you need to remember right now, just forget totally about this pathway. Just don't even consider it because we'll come to that later on. Because right now, just think about motor cortex, striatum, globus pallidus interna externa, subthalamic nucleus, thalamus, and will revolve around these things. Will not consider the substantia nigra, pars compacta in this picture. So, if you could see the direct pathway is originating in the motor cortex. Which motor cortex? It is predominantly the premotor cortex. So, in the premotor cortex, the pathway is originating. It goes all the way down to the basal ganglia, basically the striatum. And now, instead of striatum, I will talk about putamen, because you know the striatum is basically two things, the putamen and caudate nucleus, right? So, we will consider putamen in this picture because caudate is not drawn in this picture. So, from the premotor nucleus, the signals are sent to the putamen. From the putamen, in the direct pathway, this pathway, the signals are transduced directly into the globus pallidus interna, bypassing the globus pallidus externa. So signals are not relayed in the globus pallidus externa. Instead, they go directly into globus pallidus interna. From the globus pallidus interna, they go to the thalamus, and from the thalamus, they go to the motor cortex. Now, this is the pathway, that is from the premotor cortex to the putamen, to the globus pallidus interna, to the thalamus, and all the way to the motor cortex. This is a direct pathway. Now let's see what is the nature of the pathways, what is the nature of the neurotransmitter in these pathways. The premotor cortex sends the stimulatory pathway down towards the putamen, right? This stimulatory pathway stimulates the putamen. The putamen will send inhibitory signals to the globus pallidus interna. So the putamen will inhibit the globus pallidus interna, and as you can see that the neuron that is coming out of the globus pallidus interna is also inhibitory. But when the putamen inhibits the globus pallidus interna, so this inhibitory neuron is inhibited. Thus, the inhibitory signal will not go to the thalamus, and in turn, the thalamus will be stimulated, and the motor cortex will be stimulated. In return, if I draw it in the separate board, let me draw it over here. So, if I draw it over here, so the pathways that from the premotor cortex, let me make it short. So, if I am saying that the pathways from the premotor cortex to the putamen, from the putamen, the signals are going to the globus pallidus interna, from there to the thalamus, and from thalamus they are coming back to the premotor cortex. Now let's think about the excitatory or inhibitory path. Now think about the neurons which are responsible for this signaling. So the premotor cortex, okay, so yes, give me a second. The premotor cortex is going to stimulate the putamen. So the premotor cortex sends excitatory signals to the putamen. The putamen will send inhibitory signals, which are drawn by the red. So the putamen will send inhibitory signals to the globus pallidus interna. So when the premotor cortex was stimulating the putamen is going to inhibit the globus pallidus interna. The globus pallidus interna that was also going to transmit the inhibit signal to the thalamus is now inhibited by the putamen. When the putamen, GABAergic neurons from the putamen are inhibiting the globus pallidus interna, they will not inhibit the thalamus, and the thalamus, which was normally sending excitatory signals, which was normally sending excitatory signal to the premotor cortex, will not be inhibited, and the excitatory signals will reach the cortex, and the action will be performed. So you have to remember it like that in direct pathway the premotor cortex is stimulated, right? Now let's talk about the indirect pathway. In the indirect pathway, firstly we'll talk about the pathway. The pathway is starting again from the premotor cortex, right? The premotor cortex is sending signals to the putamen, that is written striatum over here. In the indirect pathway, the inhibitory neurons will go first to the globus pallidus externa. Then from the globus pallidus externa, the neurons will go to the subthalamic nucleus. From subthalamic nucleus, the neurons will come back to globus pallidus interna, and from there to thalamus, and then to the motor cortex. So why is it called indirect pathway? Because the signals cannot come from the striatum directly to the globus pallidus interna. Instead, they first go to the globus pallidus externa, then an indirect pathway is taken towards subthalamic nucleus, and from subthalamic nucleus they come to globus pallidus interna. That is why it is an indirect pathway, because neurons are entering globus pallidus interna indirectly from the putamen. Now here you can see that the premotor cortex is sending stimulatory signals. It is sending stimulatory signals to the putamen. From the putamen, the GABAergic neurons, the inhibitory neurons, are inhibiting the globus pallidus externa, right? The globus pallidus externa also normally transmits the GABAergic or inhibitory neurons to subthalamic nucleus, but since the putamen has inhibited the globus pallidus externa, so this neuron is inhibited and subthalamic nucleus will not be inhibited, because if the GABAergic neuron, if the inhibitory neuron is inhibited, the thing which it was supposed to inhibit will come out of inhibition definitely. So subthalamic nucleus is not inhibited, right? When subthalamic nucleus is not inhibited, the stimulatory neurons which were going to globus pallidus interna will be stimulated. So globus pallidus interna will be stimulated in the indirect pathway. If it is stimulated, so the inhibitory neurons which go to the thalamus from the globus pallidus interna will be stimulated, and if they are stimulated, the thalamus will be inhibited and the action will be inhibited. The premotor cortex will be inhibited and the action will not be performed. So this is how via direct pathway the action is increased, and from indirect pathway the action is decreased. You must remember this point. So if I come on the whiteboard, so this is the direct pathway. If I talk about the indirect pathway, the putamen does not go directly to the putamen is not going to go directly to the globus pallidus interna. I'm sorry, let me do this like that, and okay, so the putamen does not go directly to the globus pallidus interna. Instead it is going to go first to the globus pallidus externa. So it will go to the globus pallidus externa. So since it is a GABAergic neuron, so globus pallidus externa will be inhibited. Then globus pallidus interna, globus pallidus externa, which was supposed to inhibit the subthalamic nucleus, since it itself is inhibited, the subthalamic nucleus will not be inhibited, and subthalamic nucleus, which sends stimulatory signals to the globus pallidus interna, will come out of inhibition and globus pallidus interna will be stimulated. If it is stimulated, so the GABAergic neuron, just give me a second. If it is inhibited, so the GABAergic neuron, which is over here, okay, just wait a minute. So the GABAergic neuron that is coming out of the globus pallidus interna will be intact, that will perform its action. And if it is going to perform its action, so the stimulatory neuron coming out of the thalamus to the premotor cortex will not perform its action, and ultimately the action that was planned in the premotor cortex will be inhibited. So this is the function of indirect pathway. So if I give you the summary of everything that we have just talked about till now, direct pathway enhances the action, and indirect pathway decreases the action. So it decreases the action while the direct pathway increases action. So you must remember these 2 points normally when they are not stimulated or affected by substantia nigra in any way, right? So now let's come to this thing, the direct pathway. Substantia nigra pars compacta input stimulates the striatum, stimulating the release of the GABA, which inhibit the GABA release from the globus pallidus interna, disinhibiting the thalamus of the. Okay, so before going to the this text, let's talk about the role of subthalamic nucleus. Not subthalamic, the role of substantia nigra. So substantia nigra is a dark area in the midbrain. That is why it is called as substantia nigra. Now substantia nigra releases dopamine. Dopamine acts on dopamine receptors. The direct pathway has D1 receptors, which are excitatory receptors, and the indirect pathway has D2 receptors, which are inhibitory receptors. So you must remember these 2 points. Firstly, that the dopamine that is coming out of the substantia nigra will act on the D1 receptors in the direct pathway and D2 receptors in the indirect pathway. Secondly, now here you can see that the direct pathway always facilitates the movement while the indirect pathway inhibits the movement. Now, as we have already talked about the direct and indirect pathway, now let's put the whole picture together. When from substantia nigra the dopamine is coming and it is stimulating the direct pathway, it means that from the putamen the globus pallidus interna will be inhibited more often than it is inhibited alone without action of substantia nigra. Then globus pallidus interna that is inhibited now, it will not be able to inhibit the thalamus, and thalamus will perform its action on the motor cortex. Good. Substantia nigra via D2 receptor inhibits the striatum, right? Normally you know that the motor cortex stimulates the striatum, but when we have an influence of substantia nigra, it will inhibit the striatum. When striatum will be inhibited, so the indirect so the neurons which are coming from the striatum to the globus pallidus externa will not be inhibited, and globus pallidus externa will get the inhibitory neurons. These inhibit I'm sorry, just give me a second. Yes, when I'm sorry. So I was saying that when the what's it like that? Okay. I'm sorry. So when substantia nigra via D2 receptor is going to inhibit the striatum, so striatum will not be able to send inhibitory signals to the globus pallidus externa. So globus pallidus externa is not inhibited because the striatum itself is inhibited by the substantia nigra D2 receptors. So when the globus pallidus externa is not inhibited, so the globus pallidus externa will be able to send inhibitory signals to the subthalamic nucleus, right? When it sends the inhibitory signals to the subthalamic nucleus, so the globus pallidus interna will not be stimulated because the subthalamic nucleus is inhibited by the globus pallidus externa. When globus pallidus interna is not stimulated, so thalamus is not inhibited, and if thalamus is not inhibited, so the premotor cortex will perform its action. So the summary of it is that direct pathway is stimulatory, it is always stimulatory, while the indirect pathway is inhibitory when it is not affected by the substantia nigra, and it is also stimulatory when it is affected by the substantia nigra pars compacta. I hope I could clarify the concept, and the rest of the concept will be clarified in the further discussion. Now here you can see that direct or excitatory pathway, substantia nigra pars compacta, the C is for the pars compacta because substantia nigra has two components, pars reticularis which is a loose part of the substantia nigra, and pars compacta which is a tight part of the substantia nigra. So substantia nigra input stimulates the striatum, stimulating the release of GABA, which inhibits the GABA release from the globus pallidus interna. Okay, so this inhibiting the thalamus by the globus pallidus interna, increasing the motion. The indirect pathway, that is the inhibitory pathway, the substantia nigra pars compacta input stimulate the striatum, releasing the GABA that disinhibit the subthalamic nucleus via globus pallidus externa inhibition, and subthalamic nucleus stimulates the globus pallidus interna to inhibit the thalamus, that is decreasing the motion. Okay, this is a bit confusing. We'll see the flow sheet diagram to clarify the concept. Dopamine binds to the D1 receptor stimulating the excitatory pathway, and D2 receptor inhibiting the inhibitory pathway and increasing the motion. Now they have clarified the concept that D1 receptor will stimulate the excitatory pathway, that is increasing the motion, and D2 receptor will inhibit the inhibitory pathway, that is they will also increase the motion. So in a patient who has destruction of the substantia nigra pars compacta, that is the Parkinsonian patient, they have difficulty in starting or initiating the movement because the dopamine is not there to facilitate the initiation of the movement. So the patient with the Parkinson's disease will always have difficulty initiating the movement, and that will give us a specific constellation of symptoms associated with the Parkinson's disease. Now here is the Uworld picture. So in the direct pathway, you can see that the motor cortex is sending stimulatory signals to the striatum. Striatum is sending inhibitory signals to the globus pallidus internus directly, and substantia nigra pars reticularis as well. This is not very important. Just remember the substantia nigra pars and just remember the globus pallidus internus. The globus pallidus internus, which is now inhibited, will not be able to inhibit the thalamus, and the thalamus, which was sending excitatory signal to the cortex, will send signals, and the motor cortex will be stimulated by the thalamus. If I am talking about the indirect okay, I don't know what happened. Okay, I'm sorry. So now if I am going to talk about the indirect pathway, so in the indirect pathway, it will take a while. Just For a while, just for brainstorming, just think of it that the direct pathway is stimulating and indirect pathway is inhibiting. Now if I am talking about the indirect pathway, so the motor cortex stimulate the striatum, right? Striatum sends inhibitory signals to the globus pallidus externa. It can send these signals because I'm not talking about substantia nigra right now. I'm just talking about the motor cortex. So motor cortex is stimulating the striatum. Striatum will send inhibitory signals to the globus pallidus externa and will inhibit this externa, globus pallidus externa. Globus pallidus externa will not be able to send inhibitory signals to the subthalamic nucleus, right? So subthalamic nucleus will come out of inhibition and it will send more and more stimulatory signals to the globus pallidus interna. The globus pallidus interna will be stimulated and it will send inhibitory signals to the thalamus, and the excitatory pathway from the thalamus to the motor cortex will be inhibited. That is, indirect pathway normally inhibits the motion. But now we'll see the effect of dopamine on each of these pathways. If I'm talking about the direct pathway, so the D1 receptors stimulate the striatum. You can see that the motor cortex, it also stimulates the striatum. So there is no confusion because the rest of the pathway is the same. Striatum is more stimulated than usual. Then the striatum will inhibit the globus pallidus interna. Globus pallidus interna will not be able to inhibit the thalamus, and thus the motor activity will be enhanced. Simple. Talking about the indirect pathway, you can see that there is an opposition between the motor cortex and the substantia nigra, because motor cortex is trying to stimulate the striatum while the substantia nigra by D2 receptor is trying to inhibit the striatum, and for one reason or the other the substantia nigra inhibitory activity is more prominent than the cortical stimulatory activity. So striatum is inhibited. If striatum is inhibited, striatum will not be able to inhibit the globus pallidus externa. Globus pallidus externa comes out of inhibition and it will send inhibitory nucleus to the subthalamic nucleus. When inhibitory signals come to the subthalamic nucleus, this will be inhibited. If this is inhibited, so the globus pallidus interna, which was to be stimulated by the subthalamic nucleus, will not be activated. And if that is not activated, the thalamus is not inhibited, and thalamus will send excitatory signals to the premotor cortex, and ultimately the motion will be enhanced. So you must remember these points. Actually, to be very honest with you, the whole pathway to which we gave 20 minutes is not very high yield, to be honest, because you need to remember that D1 and D2 receptors are responsible for stimulating the direct pathway and inhibiting the indirect pathway. You need to remember the net result, that is, direct pathway always stimulates the activity of or enhances the motion. Indirect pathway normally inhibits the motion, but under the influence of substantia nigra it also stimulates the motion. And the correlation between these basal ganglioid pathways and the Parkinson's disease, these things are high yield. Other than that, these pathways are just for the physiology, they're not very high yield for the step exam. Moving forward, these are the movement disorders, and this picture is very important. You must know that which area of the basal ganglia is affected in a particular movement disorder. So I will not repeat everything about these pathways because we have already talked enough about that. Huntington disease is going to affect the striatum. Parkinson's disease specifically going to affect the pars compacta of the substantia nigra, but as a whole substantia nigra is degenerated in Parkinson's disease. The Wilson's disease will affect the globus pallidus interna as well as striatum, right? And the hemipolismus is going to affect the subthalamic nucleus. We'll talk about these movement disorders later on, but for right now just remember that striatum is affected by the Huntington disease, substantia nigra by the Parkinson's disease, Wilson's disease affects the striatum as well as globus pallidus interna, and the hemipolismus is going to affect the subthalamic nucleus. The next point is about the nigrostriatal degeneration in Parkinson's disease. Reduces the activity of the thalamus and its projection to the cortex, resulting in the bradykinesia and rigidity. Nigrostriatal degeneration, excessive excitation of the globus pallidus internus by the subthalamic nucleus, which in turn causes excessive inhibition of the thalamus. Patients with medically intractable symptoms of Parkinson's disease may benefit from high frequency deep brain stimulation of the globus pallidus internus or subthalamic nucleus, as it promotes the thalamocortical disinhibition and improved mobility. So basically the function of substantia nigra was to perform its action on the globus pallidus internus and subthalamic nucleus, right, by direct or indirect pathway. If we perform the high frequency deep brain stimulation of these nuclei, so we can alleviate the symptomatology of Parkinson's disease to some extent. Now let's talk about the internal capsule. Internal capsule is a white metal tract that is present in between the basal ganglia, and it looks something like this. it has two limbs, a posterior limb and an anterior limb. So the posterior limb separates the globus pallidus and the putamen from the thalamus. It is going to globus pallidus and putamen. This is the lentiform nucleus. So the posterior limb separates the lentiform nucleus from the thalamus. Anterior two-third cortical from the posterior limb. If I draw the internal capsule again, like suppose this is the internal capsule. From the anterior two-third of the internal capsule, like this, posterior limb, anterior two-third of the posterior limb of internal capsule, that is this area. This is the site of exit of the corticospinal tracts. Posterior one-third contains the sensory fiber, that is the thalamocortical tract. This is the sensory pathway. Thalamocortical, all the sensations come to the thalamus, and then from the thalamus they go to the higher cortical layers. To reach the higher cortical layers, those sensations has to pass through the posterior limb of the internal capsule, and to be very precise, posterior one-third of the posterior limb of the internal capsule, as well as visual and auditory fibers. They are also present in the posterior limb. The genu. So if I draw it like this, so the anterior two-third is for the corticospinal tracts, posterior one-third is for the sensory fibers. This bend, that is called as the genu. This genu is responsible for the the genu carries the corticobulbar fibers as part of the corticospinal fibers. The anterior limb separates the caudate nucleus from the globus pallidus and the putamen. It carries a portion of the thalamocortical fibers. So the anterior limb carries a portion of the thalamocortical fibers, but the posterior limb is very important and very high yield as well. There is an artery that is called as lenticulostriate artery. Okay, I'm sorry, I will not be able to write that. But lenticulostriate artery, it supplies the internal capsule, right? If the internal capsule, as you can see that in the internal capsule, a lot of tracts, the corticospinal tracts and the sensory pathways, they are clustered in a very tiny space. If there is some obstruction or occlusion of the lenticulostriate artery, if there is ischemic stroke of that artery, that will result in wide range devastation of the contralateral motor neurons and the contralateral sensations as well, right? So you must take this point this very high yield point in mind, that lenticulostriate artery occlusion can lead to very wide range manifestations of motor and sensory deficits. Then what is Wilson's disease? Genetics. Autosomal recessive mutation in the ATP7B gene. Again, I would like to emphasize that most of the disorders are autosomal recessive. If you find anything autosomal dominant, mark it, because there are very few autosomal dominant disorders. Pathogenesis of Wilson's disease: excess hepatic copper accumulation. Damaged hepatocyte leak the free copper that deposit in other tissues, basal ganglia and cornea. The clinical findings will be depending on the system that is involved. Hepatic involvement will cause acute liver failure, chronic hepatitis and cirrhosis. The neurological involvement will cause Parkinsonism, gait disturbance and dysarthria. Psychiatric complications will include depression and personality changes. And clinical findings will also include the Kayser-Fleischer rings in the cornea of the eyes. Then the diagnosis is made by decreased ceruloplasmin, which is a copper carrying protein, because ceruloplasmin is not free in the circulation, and when there is too much copper, the body decreases the expression of the ceruloplasmin and the ceruloplasmin concentration decreases, and increased copper and increased urinary copper excretion, increased copper content on the liver biopsy, and slit lamp examination can also be done to visualize the Kayser-Fleischer rings. The next point is about the brain stem. This is a very important diagram, and there is something that is called as the rule of 3, I guess, I'm not sure, the rule of 4 or maybe 3, we'll see that later on, but this picture is very important. This picture states that this is the midbrain, then we have the pons, and then we have the medulla. So in the midbrain, the two cranial nerves that are going to emit the brain are third and fourth cranial nerve, that are the oculomotor nerve and the trochlear nerve. The fifth, sixth and seventh cranial nerve nuclei are present at the pons, and these nerves are going to exit through the pons. The 9th, 10th, 11th and 12th, these are going to exit the medulla, and their nuclei are also present in the medulla, right? So we don't have cranial nerve 1, 2 and 8 are only sensory. Okay, so these are motor nuclei of the cranial nerves. Right now we are talking about the motor nerves. Cranial nerve 1, that is olfactory, responsible for the smell. Cranial nerve 2, that is optic, that is responsible for the vision. Cranial nerve 1 and 2 are not present in the brainstem. They are the they are direct extension of the brain tissue, so they are not coming out of the brainstem. The cranial nerve 8, that is the vestibulocochlear nerve, that is coming from the brainstem. but that is not motor, that is only sensory. So right now we are talking about the motor neurons, motor nuclei only. So the motor nuclei of the cranial nerve 3 and 4 are present in the midbrain, 5, 6 and 7 in the pons, and 9, 10, 11, 12 present in the medulla. It is formed of, the brainstem is formed of midbrain, pons and medulla. It is connected to the cerebral hemisphere by two cerebral peduncles and to the cerebellum on each side by the superior, middle and inferior cerebellar peduncles. Its main, it contains group of the nerve cells, that is grey matter, intermingled with the several ascending and descending fibers, that are the white matter. The motor nuclei of the cranial nerves are arranged in the brainstem as follows: the cranial nerve 3, 4 in the midbrain, 5, 6, 7 in the pons, 9, 10, 11, 12 in the medulla. The NBME point is that cranial nerve 1, 2 and 8 are sensory nerves concerned with the special sensations perceived in special areas of the cerebral cortex. The cranial nerve 1, 2 and 8 have no motor nuclei. So midbrain, now this is a cut section of the midbrain. Sometimes they give you the cut sections in the step 1 exam. So anything that looks like this is a midbrain, right? So in the midbrain you will not have a fourth ventricle. Like suppose like if I show you the cut section of pons, so you can see a fourth ventricle. For the medulla there is again a fourth ventricle, but in the midbrain there is no fourth ventricle, because fourth ventricle starts below the midbrain, and in the midbrain the only thing that you can find is the cerebral aqueduct, right? The other finding that will lead you, that will tell you that it is midbrain, will be the cerebral peduncles or crus cerebri, these things. And the most important thing, substantia nigra, the dark thing like this thing and this thing. So these things can lead you to midbrain. Now the important structures of the midbrain include the following. Will go in a counterclockwise direction. This thing is called the tectum, which contains superior and inferior colliculus and stuff like that. Then we have the tegmentum. Okay. Then we have the medial lemniscus. Dorsal column medial lemniscus is a tract that is responsible for carrying the sensations for the pressure, vibration and proprioception. Then substantia nigra, we have talked about this, the role of substantia nigra in very huge detail. It has two parts. One of them is pars compacta, then cerebral peduncle, that is also called as crus cerebri. Then in the cerebral peduncle we have divisions, and occipito-parieto-temporal fibers are present laterally. Then corticospinal fibers are present centrally. Corticobulbar fibers are present more medially. Frontopontine fibers are present like this. So this is the part, the central 3/5, I guess central 2/5 or 3/5, that is the corticospinal fibers on each side. Then we have root fibers of the cranial nerve 3. Cranial nerve 3 emits anteriorly, while the cranial nerve 4, that comes like this. It comes like this. So cranial nerve 4 is the only cranial nerve that comes behind that comes from the back side of the brainstem. Then we have the ventral tegmental area. This is the ventral tegmental area. Then crus cerebri, the red nucleus is this thing. Then we have the spinothalamic and the trigeminothalamic tract. The cranial nerve 3, and then we have the PAG. What is PAG? PAG is the I have no idea. PAG. No, I have no idea. No. Okay, so PAG. Then we have the superior colliculus over there. Now let's talk about the other picture. So in this picture they are telling you specific areas which if damaged can cause specific syndromes. So if the superior colliculus is damaged, you will have a Perinaud syndrome. Perinaud syndrome is associated with a vertical gaze palsy. Oculomotor nerve or oculomotor nucleus is present over here, then around just near to the cerebral aqueduct. Then we have the medial lemniscus and red nucleus. If the red nucleus is damaged, we will have a Benedict syndrome. If substantia nigra is gone, then we'll have a Parkinson's disease. And if we have damage to the anterior part of the midbrain, then there will be a Weber syndrome. We'll talk about the details of them later on, but for right now just remember that damage to the superior colliculus will lead to Perinaud syndrome, red nucleus damage will lead to Benedict syndrome, and the damage to the substantia nigra and cerebral peduncle will lead to Weber syndrome. What is Benedict syndrome? It is due to occlusion of the perforating branch of the posterior cerebral artery. So if the perforating branches of the posterior cerebral artery, which are responsible for supplying the midbrain, if they are damaged, there will be Benedict syndrome. Lesion in the cranial nerve 3. So if the cranial nerve 3 is gone, there will be ipsilateral oculomotor palsy, down and out gaze with a dilated pupil. If the cranial nerve 3 is not working, on the same side the pupil will be down and out with a blown out pupil, because the parasympathetic nerves which were carried by the oculomotor nerve will not be transmitted to the pupil, and pupilloconstriction will not happen, and thus the pupil will be dilated. On top of that, you know that most of the extraocular muscles are supplied by the cranial nerve 3, with an exception of superior oblique and the lateral rectus. So their action will predominate, and lateral rectus will push the eye outside, and superior oblique will push the eye down. So the eye will be down and out with blown out pupil. Medial lemniscus, if that is damaged in the Benedict syndrome, there will be contralateral loss of proprioception and vibration. And if the red nucleus is damaged, there will be involuntary movements like tremor and ataxia. So this is the area. This is involving the cranial nerve 3, the red nucleus, and the medial lemniscus. These three things are gone in the Benedict syndrome, and each of them will have a separate finding which we have discussed in the text. I'm sorry. Okay. Then we have the Weber syndrome. The lesion may involve the cranial nerve 3. It may involve cranial nerve 3 to variable extent, but the maximum involvement of cranial 3 will cause a down and out pupil with a blown out pupil. Corticospinal tracts will cause contralateral hemiparesis. Corticobulbar tract will lead to pseudobulbar palsy. Upper motor neuron cranial nerve weakness, exaggerated gag reflex, tongue spastic, that is no wasting will be there, and spastic dysarthria will also be present. Okay, so in the Weber syndrome we have variable involvement of the cranial nerve 3. Then there is involvement of the corticobulbar and corticospinal tracts, and also to some extent substantia nigra is involved. So they will result in exaggerated gag reflex, tongue spastic, no wasting, and spastic dysarthria, and upper motor neuron findings will be there because of involvement of the corticobulbar tracts, and corticospinal tracts will lead to contralateral hemiparesis. The Perinaute syndrome is due to the lesion in the posterior midbrain, often from the pinealoma and germinoma of the pineal region, which can compress the posterior midbrain, that is tectum, that will result in the Perinaute syndrome. Cerebral aqueduct, if that is obstructed or damaged, that will result in the non-communicating hydrocephalus. Lesion in the superior colliculus and the pretectal area, the person cannot look up, that is vertical gaze palsy, and pseudo-Argyll-Robertson pupil will also be present. Argyll-Robertson pupil is a very characteristic finding of syphilis, in which the pupils respond to the accommodation reflex. Pupils have an intact accommodation reflex, but the light reflex is gone, and a similar finding, there is a pseudo-Argyll-Robertson pupil, can also be seen in the Perinaute syndrome. The next thing is pineal germinoma symptoms. Precocious puberty may occur in the males and is caused by the beta hCG production. Histologically, germinomas are similar to the testicular seminomas. Aqueductal compression by the tumor may lead to the obstructive hydrocephalus. The Perinaute syndrome includes paralysis of upward gaze and convergence. These symptoms occur due to the compression of the tectal area of the midbrain. The next thing is about the pons. So in pons and medulla you will have a posteriorly located fourth ventricle. Never forget that. Then other things that will be that are of significance in the pons are the vestibular nucleus, that is for the cranial nerve 8, the cranial nerve 7, that is over here, but remember the course of the cranial nerve 7 is very important. This is cranial nerve 6, right, coming out of cranial nerve 6 nucleus. The cranial nerve 7 nucleus is over here. It will move all the way around the cranial nerve 6 nucleus to come out from the brainstem, from the pons. Then we have the medial lemniscus, that is a part of the dorsal column medial lemniscus pathway for the pressure, vibration and proprioception. Then corticospinal tract is over here. Then we have spinothalamic tract. After the spinothalamic tract we have the spinal and nucleus trigeminal pathway and vestibular nucleus. Okay, so then we have the parapontine reticular formation and the medial longitudinal fasciculus is present over there and stuff like that. Over here you can see this is a very vague picture, but okay. So anteriorly this is the cribriform plate of the ethmoid bone, and these are ethmoid hair cells, the black things which are seen. Then this is the temporal lobe of the brain. If I show you like this, so this is the temporal lobe that is visible over here. Then this is the basilar artery. Okay, this is hell of a diagnosis to find basilar artery. This thing is basilar artery. Then the next thing is, this is pons, like this thing. Why is it pons? Because we can see the fourth ventricle behind that. So this is pons. After that we have cerebellar hemispheres. So these things like this one and this one, these are cerebellar hemispheres. Then we have the fourth ventricle, as I previously mentioned. Then the middle cerebellar peduncle. So the pons definitely is connected to the cerebellum by the middle cerebellar peduncle. So this thing that is connecting the pons to the cerebellar hemisphere is definitely going to be the middle cerebellar peduncle. We have talked about this in very big detail when we were talking about the cerebellum. Then internal carotid artery is present over here. Then sphenoidal sinus will be present here. Moving forward to the medial pontine syndromes. So in the medial pontine syndromes, the lesion will be present in the corticospinal tract that will result in contralateral hemiparesis. The cranial nerve 6 will lead to lateral gaze palsy. The cranial nerve 7. So this is basically, if there is if I draw the pons like this, so this is a pons. So if there is damage to the medial pons, like the middle portion of the pons, so you can see the cranial nerve 6, the cranial nerve 6, the cranial nerve 7 will be gone, and they will have manifestations of lateral gaze palsy and facial weakness, droop of the affected side, and loss of the corneal reflex. The medial longitudinal fasciculus will be affected, that will cause the lateral gaze palsy. We'll talk about that medial longitudinal fasciculus in a big detail when we talk about internal nuclear ophthalmoplegia. For right now, just keep this in mind that medial longitudinal fasciculus will lead to lateral gaze palsy. The parapontine radicular formation also causes lateral gaze palsy, and sixth nerve nucleus also causes lateral gaze palsy. So these three things are very important for the lateral gaze: the cranial nerve 6, MLF, and PPRF. The corticospinal tract, if they are affected, they will result in the contralateral hemiparesis. The lateral pontine syndrome, they are present over here, like this and this. So the lateral pontine syndrome is there. So why is it there in first place? Because of ICA stroke or cerebellopontine angle tumor, that is the schwannoma. Lesion in the vestibular nuclei will result in nystagmus, vertigo, and nausea, vomiting. Spinothalamic tract, if that is damaged, there will be contralateral pain and temperature. Sensation will be lost. Spinal nerve 5 nucleus, that is the trigeminal nucleus, if that is gone, ipsilateral phase, pain and temperature sensation will not be present. Sympathetic tract, if that is affected, if that is damaged, there will be Horner syndrome. Facial nucleus, if involved, will cause ipsilateral facial droop and loss of corneal reflex. And if the cochlear nucleus is involved, there will be central deafness or deafness, sensory neural deafness. Then there is the Uworld part about the cranial nerve nucleus. So the trigeminal nucleus, or CN5, exits the brainstem at the lateral aspect of the mid-pons at the level of the middle cerebellar peduncles, a key neuroanatomic landmark for locating the nerve. Infarcts involving the anterior portion of the medial pons can affect corticospinal tract. Contralateral hemiparesis and Babinski sign will be present. Corticobulbar tract, contralateral lower facial palsy with dysarthria. Disruption of the corticopontine fibers convey motor innervation from the cortex to the ipsilateral pontine gray, lead to middle cerebellar peduncle. Contralateral dysmetria and dystiodocokinesis, that is ataxic hemiparesis, will be there. If I talk about the medulla, so again the very important thing that is present in the medulla is fourth ventricle. Always locate that first. After that, look for the nucleus solitarius. The dorsal nucleus, that is for the vagus nerve 10. You can also see the vagus nerve 10, this cranial nerve 10, is originating from the dorsal nucleus of vagus as well as nucleus tractus solitarius. So nucleus tractus solitarius gives rise to multiple nerves. Then we have nucleus ambiguous. Again, the cranial nerve 10 is also originating from the nucleus ambiguous. So these three nuclei, nucleus tractus solitarius, dorsal nucleus of vagus, and the nucleus ambiguous, all of them are giving fibers to the cranial nerve 10, that is the vagus nerve. Then we have the cranial nerve 12 with its nucleus that is located centrally. Then medial lemniscus is present over there. This is the medial lemniscus. After that we have the pyramids. Below the pyramids we'll have a decussation of what? Decussation of the corticospinal tracts. Then the inferior or lively nucleus is present over here. Then we have the spinothalamic tract. Then we have the spinal tract, that is spinal tract or the trigeminal tract, the spinal nucleus, that is the trigeminal nucleus over there. Hypothalamospinal tract and the vestibular nuclei. Now you can see the medial medullary syndrome. So out of all this crap, that is not important, none of that is important. Only thing that you need to remember is what will happen if there is damage to the medial medulla and what will happen if there is damage to the lateral medulla. So suppose this is the medial medulla, any damage to this will cause medial medullary syndrome, right? So why is it happening? Because of anterior spinal artery stroke. Lesion in the corticospinal tract will cause contralateral hemiparesis. Corticospinal tracts are present over here. So if there is any lesion to them, they will result in the contralateral hemiparesis. Medial lemniscus, if that is damaged, there will be contralateral loss of proprioception and vibration. And if the cranial nerve 12, that is the hypoglossal nerve, is that is gone, there will be flaccid paralysis of the tongue and deviation to the side of lesion, right? Then we have the lateral medullary syndrome. So if there is any lesion to the lateral aspect of the pons, like this was the medial aspect, suppose now I'm going to talk about the lateral aspect of the pons, if that is gone, so that will cause Wallenberg syndrome. That is because of pica stroke. Lesion in the vestibular nuclei will cause nystagmus, vertigo, and nausea, vomiting. Sympathetic tract will lead to Horner syndrome. Spinothalamic tract will lead to contralateral pain and temperature sensation loss. Spinal nerve 5 nucleus will lead to ipsilateral phase and pain temperature sensation lost. And the nucleus ambiguous, that is giving rise to cranial nerve 9 and 10, that will give rise to hoarseness and dysphagia. So this is a CT scan imaging, and you are supposed to find out what regions are highlighted. So the A is suprasellar region, the B is a thalamus, like this is a thalamus. Then the posterior midbrain is depicted by C, that is tectum. The D is midbrain, E is pons. How to find the lesions? Option 1, know the syndromes. So you have to know the syndromes. Option 2, use the rule of force. Now what is the rule of force? It is very important rule. 4 cranial nerves are present in the medulla, 4 are present in the pons, and 4 are what? 4 cranial nerves in the medulla, in the pons, and 4 above pons. Yes, okay, yes, that's true. Suppose if I'm drawing a midbrain like that, this is the midbrain, below that we have the pons, and then we have the medulla. So there are 4 cranial nerves which are coming out of the medulla. These are cranial nerve 9, 10, 11, and cranial nerve 12, right? 4 are originating from the pons, that is cranial nerve 5, then cranial nerve 6, 7, and 8, right? If I'm not wrong, I guess it is like that. No, it's not like that. Actually, the sides were problematic. So cranial nerve 12 is over here, and cranial nerve 11, 10, and 9 are like this. So 12, 11, and 10. The pons contain cranial nerve 5, 6, 7, 8, and then cranial nerve 3 and 4 are present in the midbrain, and cranial nerve 1 and 2, they are not present in the brainstem, but they are present above the pons. So this is the rule of force, which indicates that 4 cranial nerves are coming out of the medulla, 4 from the pons, and 4 above the pons. 4 cranial nerves divided into 12, like 4 cranial nerves, like 4 numbers are going to give they will be divided on 12 completely, like 3 4s are 12, 4 3s are 12, 6 2s are 12, 12 1s are 12. So these are multiples of the cranial nerve 12. They are motor nuclei are midline, right? So these cranial nerve nuclei, the cranial nerve 3, 4, 6, and 12, the number of cranial nerve, that is a multiple of 12, they will have central motor nuclei, cranial nerve 3, 4, 6, and 12. 4 cranial nerves that do not divide, they are laterally located. Their motor nuclei are laterally located in nerve 5, 7, 9, and 11. You can see that there is no cranial nerve 8. Why? Because that is a sensory nerve. It does not have a motor nucleus. 4 midline columns, which are motor nucleus, motor pathways, medial longitudinal fasciculus, and medial lemniscus. These are midline columns. The motor nuclei, the motor pathways, medial longitudinal fasciculus, and the medial lemniscus. The 4 side columns or 4 lateral columns are sympathetic pathways. Sympathetic pathway, that is coming down from the hypothalamus to the stellate nucleus in the sympathetic chain ganglia. The spinothalamic tract, that is also lateral. Sensory nucleus of cranial nerve 5 is laterally located, and spinocerebellar tract is also laterally located. So you must remember the rule of force very you must learn it by heart, because it is very important and very easy. It makes everything very easy for you. I will repeat that. The 4 cranial nerves are present coming out from medulla, 4 from pons, and 4 above pons. 4 cranial nerves divide into 12, like 3, 4, 6, and 12, and motor nuclei are midline. 4 cranial nerves do not divide by 12, which are 5, 7, 9, and 11, and they are located laterally. For the columns, 4 of them are midline, that are motor nucleus. It is actually motor nucleus of trigeminal nerve that is located medially. Not all the motor nuclei. For other motor nuclei we have already talked. But if I am saying the but that is not midline because cranial nerve 5 is over here. So I don't know about the motor nucleus, but the motor nucleus is present. So maybe it is a dorsal motor nucleus of the vagus. Can be a thing. Yes, motor nucleus of the vagus is located medially. Then we have the motor pathways, the medial longitudinal fasciculus. What are the motor pathways? The corticospinal tracts. They are located medially. The medial longitudinal fasciculus, which is connecting the sixth nerve nucleus with the contralateral third nerve nucleus, the medial longitudinal fasciculus, that is also present in the midline. And then we have the medial lemniscus, that is the pathway of that is the tract that is carrying the fibers from the dorsal column. So dorsal column medial lemniscus pathway, that is also midline in its location. Therefore, lateral side column, that is sympathetic, spinothalamic, sensory nucleus of cranial nerve 5 and the spinocerebellar pathway. Localizing the lesion. How do we say that if a lesion is medial versus lateral? So which tract is affected? Medulla versus pons versus midbrain. Now here you can see that which cranial nerve is affected. So in the midline we have the nuclei for the cranial nerve 3, 4, 6 and 12. The cranial nerve 5, 7 and 8 nuclei and 9, 10 and 11 nuclei, they are located on the sides, right? So the medial tracts are motor nucleus, the motor pathway, MLF and medial longitudinal fasciculus, they are located medially, like over here. The side pathways are sympathetic, spinothalamic, sensory fiber 5 and spinocerebellar, they are located on the sides. So you must remember it like that, and this will help you localize the lesion in the brainstem. So this is midbrain, pons and medulla. This is central nervous system and these are the tracts and stuff like that. Okay, so cranial nerve lesions. Hints. Olfactory nerve, it is not in the midbrain. Yes. Cranial nerve 2, it is also not present in the midbrain. Oculomotor nerve 3, the eye will be turned out and down. So down and out position of the eye will clue you into the lesion of the cranial nerve 3. The trochlear nerve, if that is damaged, eye is unable to look down when looking down the nose, looking towards the nose. So people who have trochlear nerve damage, they have difficulty moving down the stairs or reading a book because their eyes will not look down. They have a lesion in the trochlear nerve and they cannot use their superior oblique muscles. Then the trigeminal nerve will lead to ipsilateral facial sensory loss. Abducent nerve, cranial nerve C. Oh, I'm sorry. If the trigeminal nerve is damaged, there will be ipsilateral face sensory loss. So if the person is having loss of sensations in the right side of the face, so the right side trigeminal nerve is being damaged. Abducent nerve, cranial nerve 6, ipsilateral eye abduction weakness. So I will not be able to look outside. I will not be able to abduct. The facial nerve 7, palsy, will lead to ipsilateral facial palsy, weakness or droop. And auditory cranial nerve 8, damage will lead to ipsilateral deafness. The cranial nerve, glossopharyngeal cranial nerve, the glossopharyngeal nerve or the cranial nerve 9, if that is damaged, there will be ipsilateral pharyngeal sensory loss. If the vagus nerve 10 is gone, there will be ipsilateral palatal weakness. Spinal accessory nerve, the cranial nerve 11, ipsilateral shoulder weakness will be there. And if the hypoglossal nerve is damaged, there will be ipsilateral weakness of the tongue. The next point is the rule of 4 caveats. So suppose the trigeminal nerve lesion. So if the trigeminal nerve is lost, the lesion loss of the ipsilateral pain and temperature sensation of the face. The rule of 4 pons, nuclei and the trigeminal nerve, as the rule of 4 state, the trigeminal nerve is present in the pons and it is a side tract, right? Do not use to localize to pons extended in the pons and medulla, but trigeminal nucleus, it is very specific that it is a problem. It cannot be used to localize pons because trigeminal nucleus is very extensive. It starts from the midbrain, enters the pons and the medulla, so it is present throughout the brainstem and you cannot use it to localize the pons. Used for the lateral tract localization. If we are having trigeminal nerve lesion, so we cannot say that the lesion is in the pons, but we can say for sure that the lesion is in the lateral aspect of the brainstem. The second thing that you need to know is vestibulocochlear nerve. Do not use vestibular signs to localize the pons. Vestibular signs can be in the medulla or in the pons because the vestibulocochlear nucleus, if I draw the pons and medulla, so the nuclei are located like this. This is the vestibular nucleus and this is the cochlear nucleus. So they are present on the border of the pons and medulla. So if there is some problem with the vestibulocochlear nerve, the lesion may be in the pons or maybe in the medulla, right? So the lesion if it is causing hearing loss, that can be used to be in the pons. The hearing loss is because the hearing tracts are ascending in the pons. So if there is specific hearing loss, so that can be used to localize the pons. Otherwise, the vestibulocochlear nerve cannot be used to localize that. There is a case that is a 75 years old man present for the evaluation of weakness. He reports that 2 hours ago he suddenly was unable to move his left arm or leg, so there is left-sided weakness. He denies any difficulty with the speech. On examination, if speech is intact, so it's not a medullary problem. On examination, he is able to move all the facial muscles normally, so cranial nerve 7 is intact. There is no ophthalmoplegia, cranial nerve 3 is intact. On tongue protrusion, the tongue is deviated to the right side. That is to be noted. The tongue is deviated to the right side. He is unable to detect the lower extremity sensation and vibration on the left side. So there is contralateral loss of vibration and vibration sensation, right? And there is also loss of, the tongue is deviated to the right side, means that the lesion is residing in the medulla most probably. So complete motor weakness, no middle cerebral artery or anterior cerebral artery stroke. So if there is complete motor weakness only, so there is no middle cerebral artery or anterior cerebral artery stroke. Tongue is involved, which means there is a brainstem lesion. Motor pathway is involved on the left side, which means there is right medial lesion, because motor pathways are located medially. Then medial lemniscus involved, that is vibration proprioception is gone, so it means that there is right medial lesion. Cranial nerve 12 is involved, that is tongue deviation, so it means medulla is involved. So the answer is right medial medullary syndrome, and the artery that was occluded was the anterior spinal artery. This table is very important. I guess we should do this and then we'll go to then we'll wind up this session. So for the midbrain, you can see the centrally located motor nuclei for the 3, 4, 6 and 12 cranial nerve, and 5, 7, 9, 10 and 11 cranial nerves are located laterally along with the cranial nerve 8. So the posterior cerebral artery is going to supply the midbrain, both the lateral and medial halves. The ICA will supply the lateral part of the pons, and the basilar artery will supply the medial part of the pons. The pica will supply the lateral part of the medulla, while the anterior spinal artery will supply the medial part of the medulla. So we'll keep the session till here, and we'll continue from the ventral view from the next session. Until then, Allah Hafiz, fi amanillah, and take care.